I'll do the introduction separate.
Okay.
Well, no, I guess I'll do it now. So this is Dr. McWilliams. She's a psychologist and psychoanalyst. She's known for writing the trilogy, in my opinion, of psychoanalytic work. It's Psychoanalytic Diagnosis, Psychoanalytic Therapy, a Practitioner's Guide, and Psychoanalytic Case Formulation, and then most recently, Psychoanalytic Supervision. Also is the editor on the Psychoanalytic Diagnostic Manual, with an Italian man with a name that starts with V that I can't pronounce.
Vittorio Linciardi.
Vittorio.
And it's the Psychodynamic Diagnostic Manual.
Correct. The thing that stands out for me with Dr. McWilliams, I find her writing to be incredibly accessible. I feel like Dr. McWilliams takes incredibly difficult concepts and makes them seem like they're incredibly obvious. A lot of times there will be something that I don't understand, then I'll read Dr. McWilliams' formulation on it, and then it seems like it's clear as can be, and I go back and read the other person, and then it makes more sense. I read a comment on YouTube that described her writing style as having tea with a beloved supervisor, and I do feel like that is her writing style, and that it doesn't feel like it's this difficult, challenging, obscure feel. She makes it so it's accessible and easy, and what I think is most impressive with her work is I find that it helps me in my own life and my own therapy and helps me understand my own dynamics. I also think, I don't know if you do this intentionally, I don't know if you bring up your own struggles sometimes or your own personality. And I feel like in a way you make it more human to be a therapist and more human to be an analyst. You talk about yourself and your dynamics, and you make things that personality disorders seem like they're very humanistic, in the sense that I'll read about narcissistic personality disorder and I'll see myself in it, and I'll read about paranoid personality disorder and I'll see myself in it.
Yeah.
I think that really shows the level of empathy, and that you get into the person that often we pathologize and you understand them in a human way. So that was my introduction.
Very nice. Thank you.
So to get started, we're going to be talking, kind of following the Psychoanalytic Diagnosis book. So with personality disorders, I see a lot of clinicians who view the disorders as discrete, totally separate entities. And in my training, I saw a lot of people trying to figure out what the right diagnosis was or to fit someone into a box. I think with this book, you did something that was really smart, in that you adopted the DSM diagnoses so that the new reader would go in thinking they were going to learn more about these specific disorders. And I feel like you introduced a totally different paradigm as a way of thinking about these disorders. The way I view it in terms of is you introduce the idea of a central dynamic where affective and defensive pathologies kind of tend to cluster around. But I think you acknowledge the complexity with all these disorders, and that there's so many elements. Sorry, I'm kind of rambling. I gotta stop. So I think this book helps you to understand that these people don't fit into clean boxes, and it really introduces you to the problems of the DSM. I'm curious, what do you feel like are the problems with the DSM? What's your understanding? You talk a little bit about how the DSM came to be, and why there's certain flaws in it.
Well, that's asking a lot of questions all at once.
Sorry.
But my background was in personality. My PhD is in personality and social psychology, and I became a clinician. So I'm technically a clinical psychologist, but my background is studying personality. And the personality types that are in my book pre-existed the DSM, pre-existed the 1980 edition, which is what I was reacting to when I first wrote the diagnosis book, because the DSM in 1980, the framers of it were being very influenced by certain groups of researchers, by the drug companies, and by certain problems that had arisen in the field. For example, there were different theoretical orientations, and they needed a way of describing psychological problems so that you didn't have to have psychoanalytic training to diagnose them. And if you were behaviorally trained, you could still talk about the same phenomena. You could agree across theoretical orientations, But what was most important was researchers were having a lot of trouble with clinical diagnosis as it was actually practiced naturalistically, which was more that you sit down and you try to get to know a person, and pretty soon you get a sense of their personality. And it may not be a disordered personality at all. Everybody's got a personality style or type, or a combination of styles and types, and it's not necessarily a disorder. So that was the atmosphere in which I was originally trained. But when the DSM made its paradigm shift in 1980, it decided, for various reasons that were very well intentioned, that it wanted to make a categorical nosology or categorical taxonomy, meaning that you'd have present versus absent criteria, and they would be discrete criteria. They didn't want dimensionality, a little of this, a little of that. They wanted to talk about specific entities, and that was partly for researchers, because researchers need to figure out, you mentioned narcissistic personality disorder. If they went to therapists before 1980 and said, well, how do you diagnose narcissistic personality disorder? Therapists would have said, well, you take the person into treatment and you see what the transference is like. And if it's a self-object transference, presumably the person has mostly narcissistic dynamics. And that's no help at all for researchers. They wanted present versus absent categories. So the DSM tried to be neo-Kraepelinian, meaning that clinical psychiatry and psychology and social work had all gone in the direction of dimensionality, complexity, seeing people in context, inferring meaning. But if you're going to try to do research on specific things, like specific kinds of depression, you have to have rule-outs so that you're not mixing things up. And that created a lot of problems. One problem was the most common kind of personality type that existed in the literature, including the empirical literature before 1980, was depressive personality. But people on the Mood Disorders Task Force didn't want to have depressive personality in there. They thought it was too muddy a concept compared to depressive illness. And the drug companies who were funding a lot of these people also didn't want depressive personality in there, because it was already known that antidepressant medication isn't very helpful if you've got the personality problem rather than just a discrete depression. So they eliminated depressive personality disorder from the DSM. In fact, the whole personality section of DSM-3 and subsequent DSMs, until the most recent one, which has an alternative classification system, was an afterthought. You know, they were more interested in anxiety disorders, depressive disorders, addiction disorders, and so forth. And that's why it's at the end. And what they did at the end was only add personality disorders on which there was an empirical literature. That meant getting rid of some, like inadequate personality, on which there wasn't an empirical literature. It also meant they got rid of the idea of dimensionality, and that was a problem because borderline originated as the idea of a kind of personality organization not crazy enough to be psychotic, but crazier than neurotic. So in other words, it was a mid-level kind of level of severity of personality problems, and you could have a schizoid personality at the borderline level, an obsessional personality at the borderline level, and so on. But the empirical literature that had been done had mostly been done on people who had more histrionic versions of borderline personality, and so they took those criteria, mostly from John Gunderson's work, and made it a category. So then there was borderline personality disorder, and it was described as, self-dramatizing and having trouble with affect regulation and all the things that we're familiar with. But that's really only one version of being organized at a borderline level. And then they got upset because, if you meet the criteria for borderline personality disorder in the DSM, you probably meet the criteria for histrionic personality disorder too. And they said, we can't have that. Well, there's a perfectly good reason they have that. Gunderson was the head of a hospital, and he was most interested in borderline patients who were causing trouble. He wasn't that interested in the schizoid borderline patient who spends all of his day in the room playing video games and doesn't ever see people and is not self-dramatizing and doesn't cut himself and so forth. So they were trying to solve some problems by making the DSM from 1980 on neo-Kraepelinian, categorical, non-dimensional, non-inferential. The previous DSMs had been heavily influenced by psychoanalytic ideas, and there were plenty of people that didn't want to be fed psychoanalytic ideas with their diagnostic categories. So they were quite well-intentioned, but it created certain kinds of clinical problems that they didn't fully foresee. I mean, even in the language of the DSM, you can find places where the authors say, these categories don't substitute for clinical judgment or a good case formulation, and things are really a lot more dimensional and complex than this. But and they didn't intend it to be used as the Bible for everything. Gotten to be that, and I think that's quite a problem. And my concern has been the reason I wrote the diagnosis book was I was finding that certain knowledge that we had as practicing therapists was getting lost because the DSM was treated as the be-all, end-all of understanding people. And that's really a shame. It wasn't intended to be that. It's useful for certain kinds of research, but other kinds of research, like on personality differences, on attachment, on neuroscience, on development, things that don't lend themselves to the test of a particular technique for a particular set of symptoms, are, as a result, kind of devalued in general. And I've seen the difference clinically. I mean, it used to be people would come and they'd say to me something like, I'm very shy. I need help getting more comfortable around other people. I'm an introvert. And now they come and they say, I have social phobia. What do you think what medicine should I be taking? Or give me a skill set for that. And it's a very different mental set that has been the result of the DSM. The drug companies love the DSM because if you have discrete categories, you can market drugs for them. And certain researchers like the DSM because it makes their research cleaner to eliminate any comorbidities, so-called. In fact, some of the evidence-based treatments have eliminated so many comorbidities when they study a particular disorder that the patients represent the healthiest people in that category and not the kind of people who come into our offices. And it's served the interests of government cost cutters, too, and insurance companies that say, well, if these are the disorders that we cover, and we don't cover these more complicated things like complex post-traumatic states or personality disorders. I mean, it's interesting. The insurance companies marketed their managed care policies to corporations saying that they gave comprehensive mental health care, and then they very quickly said, oh, but we don't cover personality disorders. That's not comprehensive mental health care. Whereas we have plenty of empirical data that most people who come for therapy have some involvement with their lifelong patterns of relatedness, their personality, not just with a one-shot anxiety disorder or eating disorder or other disorder category. But it's in the interests of cost cutters, whether they're private or public, to see it as, oh, you got rid of the immediate symptoms? Fine. We don't do that in the rest of medicine. You don't lower a fever and say, okay, problem solved, or cure a skin rash and not be interested in what it's telling you about what's going on in the body. And you can describe a limp in terms of present versus absent criteria, but you're not saying that it is the disorder. You can limp for any one of a number of reasons, and in the rest of medicine, you try to figure out what those reasons are. So we've done a peculiar thing in psychiatry where we're substituting symptoms that tend to cohere together for an idea about what's really the problem here that the person needs to work on. this is probably more information
No,
than
that's
you
great.
wanted, but that's what made me feel, it wasn't exactly like I took the DSM categories and then switched the paradigm. It was that the DSM categories, to a certain extent, reflected our understanding prior to the switch in 1980 of what the different personality disorder possibilities were, with some omissions. For example, there's no sadistic personality in the DSM, even though everybody knows that there are a very small number of people who are organized around sadistic dynamics. They don't tend to volunteer happily to be research subjects, so you can't say there's an empirical basis for the category. So they just omitted that. We don't have the hypomanic personality type in there. There are some people who are stably hypomanic who don't have diagnosable bipolar illness, but they've disappeared from the DSM because they don't tend to be very, constant about cooperating with researchers. So it's kind of a mess. What I was trying to do was keep alive clinical knowledge that came from scholarship and clinical experience that had gone on for quite a while by 1980 and has gone on since 1980. So that's what I was trying to do. I was trying to be useful to my students. It was my students that pushed me to write that book. They got sick of hearing me bitch that there should be a book like that.
Yeah, I read it before residency and just thought entirely differently than everyone else, and found that the DSM didn't match what I was seeing in reality, and found that the diagnoses simplified people.
Yeah.
And with your approach, I found that I was able to understand them better and see more of the complexities in the people. But I have a million questions that I wanted to have you expand on, but I do want to keep moving so that we can touch on lots of topics. You brought up the borderline organization. Can you just talk a little bit more about I guess you described it as there's two dimensions in terms of personality. And like your one friend in your book, you mentioned they say how nuts and what type of nuts.
Yeah, that's right.
Can you talk just a little bit more about the neurotic, borderline, and psychotic spectrum?
Yeah, that comes originally from the work of Otto Kernberg, who was noticing, like any experienced clinician, that personality problems run on a continuum from healthy versions of a kind of psychology through neurotic versions of it, through really more troubled versions of it that we would think are more diagnosable as personality disorders, to psychotic versions of it. And for example, and I don't mean necessarily schizophrenia, there was before, in the 1960s, there was a diagnosis of hysterical psychosis, for example, and I think that it's a loss we don't have that now. But at any rate, the first person to write about this was Elizabeth Zetzel. She wrote an article called The So-Called Good Hysteric, because psychoanalytic treatment was invented with people with what were then called hysterical disorders. We've now mostly diagnosed those as post-traumatic or histrionic or dissociative. But she talked about how high-functioning people with hysterical psychologies are very easy to work with. They make a very easy connection with the therapist. They understand that they're working on themselves. They experience themselves as having internal conflicts that they could work on. They can be pretty neurotic, but if they can have kind of sense of self-constancy and make a good relationship with another person and see the problem as internal, they would be in the neurotic range of personality disorder. If they're getting into trouble a lot with their dynamics, you'd still call them a personality disorder, but at the neurotic range. Zetzel didn't use those terms, but she had 4 categories of levels of hysterical psychology. There are a couple of levels we now diagnose as borderline, where there's much more self-dramatizing, much more enactment outside the self, much more creating disasters. The same internal preoccupations in the case of hysteria with issues of gender and power and fear of impingement and fear of other people in the other gender. Usually they're they think in very binary ways, dominating them. Those dynamics will run through the whole level, but at the borderline level, it can be enacted as people having series of horrible relationships that all end up coming to a bad end, involving domination, sexuality being a problem, and so on. And then at the psychotic level, you see people who are so chronically creating crises all the time and believing their own fabrications in certain ways. Like I tend to think of Munchausen's as at the psychotic end of the hysterical continuum, because the whole drive for people with Munchausen seems to be to matter to the medical establishment, to matter to doctors. If it's Munchausen's by proxy, it's to get this drama going where their child is at death's door and somebody saves them, and it's a wonderful outcome, and then they have to repeat it. That's a crazy level of enacting the same dynamics. So she was the first one to write about it. Kernberg in 1984 talked about how it's much more important to know what level the person is at than what their dynamics are. So, for example, in the obsessive-compulsive dimension, a healthy obsessive-compulsive person is just somebody who's very well organized, kind of type A, has pretty strong moral principles, is interested in issues of control, maybe a little bit wooden, but in general a good citizen all around. The neurotic range of obsessive-compulsive would be somebody who has ritualistic practices that they know are crazy. They know it involves internal anxiety that they have to do something about. They can make a good relationship with a therapist. They can see that the problem is internal. They're easy to work with. They would respond well to any of the short-term therapies, especially exposure therapy. At the borderline level, you see obsessive-compulsive people who are, for example, hoarding or crazily involved with their rituals, and they kind of know they're crazy, but they have to do them, and they have a much harder time making a relationship with a therapist or thinking a therapist could really help them. At the psychotic level, it's pretty hard to, there's a kind of very soft category between, or soft boundary between being extremely obsessive and being paranoid. And at the psychotic level, you get people who firmly believe that if they don't do their rituals, they will be destroyed. And if a therapist tries to get them to use exposure therapy, for example, or to question their rituals, they simply believe the therapist has turned into a persecutor now and doesn't get how dangerous everything is. So you can see how it would be easy to work with the healthy or the neurotic version of obsessive compulsive. It would be more challenging to work with a more borderline. And with the more psychotic person, with the same dynamics, which involve issues of control and discontrol, neatness and messiness, promptness and lateness, cooperation and resistance, all those dyadic struggles are the kind of core of obsessional psychology. You can see that at the borderline and psychotic levels, it would be really rough going. You'd have to spend, especially at the psychotic level, you'd have to spend months or years becoming a safe enough other to the person who's suffering, that person to be able to imagine, maybe I could try something that this therapist is suggesting, to expose myself to what I think are going to be the disasters that accompany my not doing my rituals. So that really came from Kernberg's work. There's now considerable empirical work supporting the idea of dimensionality. Carla Sharp's work, for example, is, I think, very powerful empirical demonstration of the value of thinking this way. Patrick Leuchten has done some work on this as well, Ken Levy. Most practicing therapists have always seen it this way. So it matters clinically, not just, what kind of nuts, but how nuts the person is. Or maybe they're not nuts at all, but you want to take into consideration what their personality is. There are plenty of introverted people who see themselves as on the schizoid side, who don't have significant psychological problems, might come to a therapist for a depression or an anxiety or an eating disorder or something. If the therapist appreciates that they have a schizoid psychology, you don't necessarily try to modify that, but it helps you to understand that that's the kind of patient that will do better if you give them a lot of space rather than if you move in on them, in contrast to somebody who's more, let's say, depressive or hysterical in their organization, where they move toward people, and if you give them a lot of space, they feel abandoned. So even at the highest functioning levels, to know something about personality differences, even if there's no disorder, helps you orient therapy to make a person comfortable enough to get into their stuff with you, to show the disowned parts of themselves to you, to move ahead with their work.
So I do want to move to the different styles, but I do want to, there's a question I have. So you talked about the difference between kind of how we use borderline today as a distinct personality disorder versus what is intended here, which is borderline personality organization.
Yeah.
Can you talk a little bit about the difference between, I guess when I use psychosis, I think of more of a schizophrenia psychosis. Mm-hmm. What you mean? What would be the difference between a schizophrenia psychosis and the psychotic level that you're discussing here?
Well, that's a big question, because I'm not sure I buy into the idea that there is such a thing as schizophrenia. I think there is psychotic experience, and certain things map onto what we've called schizophrenia. But let me put that aside, but say that you can, if you use the term psychotic in the way that it was originally meant, namely, there's a problem with joining with consensual notions of reality, okay, then you see a number of people who aren't diagnosably schizophrenic, but who are struggling to stay in reality, or who have some really crazy ideas. For example, one man I worked with who was on the paranoid side but never had had a psychotic break. He was in his 50s or 60s when I worked with him. I noticed a few sessions into our work that when he started feeling sad, he would cut himself off and change the subject. So I brought that to his attention. I said something like, I think I'm noticing that when you start to feel sad, you change the subject. And he said, oh yeah, I know I do that. And I said, well, what's going on when you do that? And I think I expected him to say something like, well, I don't want to start crying, or I'm not ready to go there yet, or something like that. And he said, well, I can see I'm hurting you. Okay. So he kind of thought he could read my mind. He thought it was his job to keep me safe. He couldn't imagine another person showing sadness. He would see sadness on my face, and he would feel he was destroying me, and he had to stop. And that's crazy in the sense of not having a good boundary between self and other. I mean, and that's really usually what's going on in what we call psychosis. You're hallucinating things that you think are outside you when they're really expressions of dynamics that are inside you. Or I had a woman who was telling me about how she had a particular kind of urinary problem, and she said something about the urethra being like a tube. And I said, well, the urethra flattens out, it closes up against, it's not mine, it's a tube. She looked at me as if I was dangerous. Or another patient who, she came late one day, and I said, it's not like you to come late. She said, oh yeah, it took me longer than usual to boil all the sheets and towels. And I said, you boil all your sheets and towels? And she immediately looked at me with distrust. I'd seen her for several years by this time. And she said, "Of course I boil all my sheets and towels. Haven't you ever heard of germs? What good mother doesn't boil all the sheets and towels every morning?" And she was looking at me like I was a contaminant all of a sudden. Now that's a crazy level of obsessive neatness. It goes beyond just borderline. There's a terrible anxiety that the world will fall apart if you don't control it somehow in that kind of psychology. So, and that's how people used to use the term psychosis. And when the DSM in 1980 decided we're going to label, the handful of psychotic conditions that we know about, I think they made some rather arbitrary choices. For example, I think extreme anorexia is a psychotic condition, because when a person weighs 82 pounds and is starving themselves and tells you that they're too fat and sees an obese person in the mirror, that's completely crazy. It goes beyond neurotic or borderline. But we don't think of extreme versions of anorexia as a psychotic illness, and I wonder why not, because there's a loss of touch with reality there. In certain post-traumatic states, people believe you are the Viet Cong right now. They can be sitting with you in a session, and all of a sudden the therapist is the rapist, and they will act as if you're just about to attack them or just did attack them, and it takes a while before they can come back to now. And that's a post-traumatic phenomenon, but in the moment they're psychotic. So I'm using the term in the general way that clinicians have used it, because I think these discrete categories blind us to the ways in which we all have we could all go mad in one way or another. Maybe not, we don't all have the biological predisposition to be diagnosably schizophrenic at any point, but different people's minds fracture along different patterns, but we can all be really damaged. And if we separate out these few symptomatic constellations and say, well, that's other, we lose the capacity to empathize with what it's like to go there. And if you lose that empathy, you're not going to be experienced by the patient as respectful.
You talked about the man who thought he was hurting you when he would talk about content that hurt himself. I think it makes me want to, I think this is possibly relevant, the difference between mature and primitive defenses.
Mm-hmm.
I think can you talk a little bit? I think you formulated, because when I learned it in medical school, it felt like it was just like healthy and unhealthy. It wasn't really clear what the difference was. You formulated, I think, is the boundary between the primitive ones are the boundary between the self and outside world, and then mature is the boundary between the internal psychological structures.
Pretty much, yeah.
Can you say a little bit more about, I guess, mature and the primitive defenses?
Well, first of all, we all have primitive defenses. It's not just the sick patients. The primitive defenses, and I'm using primitive not in a way to try to pathologize them, but just to descriptively say they come up early in our experience. They're the way young children deal with the world, and those ways of dealing with the world never die in any of us. They include withdrawal. If you're overstimulated, an infant will withdraw, go to sleep sometimes. Denial, which is it's not happening. Tell anybody that somebody's just died, and the first thing they'll say is, "Oh no." Okay, that's the residue of denial. I don't want this to be true. It's not true. There are primitive forms of idealization and devaluation. There are primitive forms of dissociation, where you literally become somebody else. Splitting is a very important primitive reaction. It's where you organize experience as all bad or all good. And we all do that, especially under stress. You know, on 9/11, people weren't going around saying, gee, we're so curious why people in certain Arab countries would hate us so much. I mean, what do we represent to them that they would want to kill themselves in order to get back at us? We were going completely to they're evil. They're the evil empire. There are three parties in the evil empire. We're the good guys. So we shift into good and bad rather than complex understandings of things. And that's the way very young kids organize the world. Good, bad, big, little, and sometimes male, female are the binaries that they tend to generate starting around age 1.5 or 2. And those remain with us, and they come up under stress. You know, if your partner breaks up with you, you don't immediately go to, gee, I can understand why, given his history, he wouldn't have found me the right partner. You go to, he's a bastard, I hate him, you know. So that's splitting. And primitive forms of projection, where we can't quite know the difference between inside and outside. We think the infant has to learn the difference between inside and outside. They get more of it than we used to think, because studies of infants have now shown that they have pretty good capacity to see another, but they do kind of treat the mother and father as parts of themselves until they're a little bit older. And they tend to impute all kinds of power to us, too. Omnipotent control is a primitive defense. So is somatization, where you get sick. You know, very young children, if they don't have the words for what they're feeling, they'll tend to act out or get sick. So acting out and getting sick are primitive defenses, too. They're just processes that become defensive later on when people are struck with a lot of stress. What makes a difference as to whether you're able to be more adaptive in the world is not that you have primitive defenses, but it's more that you don't have adaptive higher order defenses. Like repression is a higher order defense than denial. To allow something to exist, to acknowledge that it's true, and then to, for motivational reasons, forget it, means you didn't fully deny it. Rationalization, most people think of as a higher order defense, certainly intellectualization. And there are some defenses that are so adaptive generally that we consider them the kind of good defenses, like using a sense of humor to deal with things. Sublimating things, like if you have a primitive wish to exhibit yourself, you could become a singer or an artist, you know, and do some social good with your wish. Or if you have fantasies of sadistically cutting people, you can turn that into becoming a surgeon and do the world a great deal of good. And it may have been based in early childhood experiences where you wanted to hurt somebody, but it's turned into a positive. So there's a whole range of what we call defenses, which may not be the best word, but we're stuck with it because we've observed them in their these processes mostly in their defensive function. And there's a long list of them, and they've been studied empirically by people like Phoebe Kramer and Chris Perry and George Valiant. So we know, something about when they emerge and how people get better defenses as they get older. For example, a 4-year-old or 5-year-old kid, if they are displaced by a sibling, you can see reaction formation in that kid. But a 2-year-old displaced by a sibling, you won't see that. Reaction formation is, oh, you're so cute, I'm determined to love you, and I really am, pinching your cheek in a way that you can kind of see leaking through the hostility. But they're trying to feel positive about the new baby, and younger kids aren't capable of that.
Mm-hmm. Yeah, see, my nephew squeeze my knees so hard, and it's like, oh, good Jack, you love it, babe, you know?
You're right.
So I want to move to the different personality styles. I just want to check in. How are you doing on energy? Is the light
I'm good.
too bright?
No.
I was worried it's just going to be, okay. All right, so I guess let's start. We're just going to go one through each one.
Okay.
So starting with paranoid personality style. Do you want to give an overview, or do you want me to ask specific
Yeah, let me
questions?
give an overview
Okay,
here,
perfect.
because what we mean by personality, the DSM tried to describe personality based on traits, the presence or absence of traits. And I think that's highly problematic, because what really organizes personality is something more like themes and stories. What's the primary narrative of the person, or what some of the cognitive folks call schemas. So you'll see traits that aren't, it's not wrong to say, for example, using paranoid as an exemplar, that paranoid people have the traits of suspicion and distrust. It's not wrong, but it's incomplete. It doesn't capture the fact that paranoid people also can be pathologically over-trusting. A paranoid person can tell you their cult leader is flawless. Okay? They can believe fervently that somebody is totally trustable. Sullivan said they don't have medium and realistic capacity to deal with trust and distrust. They're all organized around the issue of trust and betrayal. That's their theme. That's their issue. So it's not just that they have certain traits, but that you can see behaviors on both ends of the continuum of ways of dealing with that theme of who can I trust and who's going to betray me and how am I going to get hurt here, the kind of basic insecurity that runs through paranoia.
And what you're saying makes it so, if it's viewed as traits, it seems very paradoxical that there are two extremes of the poles.
Right.
Of one, and through each personality disorder, you see these, what would be paradoxes if people would view it as traits. Narcissism, high self-esteem versus incredibly low self-esteem.
Yes.
And if you view it as a trait, you're really missing kind of what you're saying, is that why it's not it's not as confusing as it looks, I guess.
Yeah, I mean, and in a way it sounds paradoxical, but it's also kind of common sense that if you're organized, like obsessive compulsive people tend to be organized around neatness. Mm-hmm. You know, everything is organized, but they also tend to have a mess somewhere. They have a dirty drawer somewhere. They can't organize certain things. You see an oscillation between neatness, messiness, control, discontrol, obedience, rebellion, submission, provocation, promptness, lateness, all the dyadic issues that they get organized around. Or you mentioned narcissistic. Yeah, there's the arrogant version of feeling better than other people, which is a compensation for the fact that you feel worse than other people. And you see both sides of that in every narcissistic person I've ever worked with. If they run into a narcissistic injury, you'll see the side of them that feels desperate and empty and lonely and not good enough and shamed, as opposed to contemptuous and arrogant and grandiose and so forth. Mm-hmm. That's true with all the personality types. They cluster together mostly because of the story that illuminates the person's thinking about life than any particular traits. Mm-hmm. The DSM alternative personality classification is a big improvement on the regular DSM personality categories. But unfortunately, from my perspective, it's dimensional. That's why it's a big improvement. But they try to do it based on traits. And you can measure some traits, and there is a very robust empirical literature on the so-called Big Five personality traits. But they're not as clinically relevant as these stories that I think practicing clinicians can spot in any given patient. Oh, this is the third time they've talked about how somebody got too much under their skin and they were overstimulated. I think I'm dealing with a person with a schizoid psychology here. Or I'm sitting with a woman who's constantly telling me how bad men are or how wonderful men are. So she seems to be very organized around gender differences and very binary in her orientation. And there's stuff in her history that makes me think she felt defensive about being female, and she was the recipient of a certain amount of sexism. And so her issue is issues of gender and power. And you can see, again, there are some very self-dramatizing versions of hysterical personality and very inhibited versions of hysterical personality, but the dynamics are the same. So that's sort of what I wanted to say before I talk about the specific personality types.
Yeah, that's what, like when you mentioned like the big five, like, and the different paradigms of problems that I see in psychiatry with monoamines. What I notice is that with the dynamic view, it really gives you a live picture of the person. Whereas when I feel like I have an understanding and a mental picture if you tell me someone has a more narcissistic personality style. Whereas if you give me the five big traits, I don't have a picture of what that person is.
Yeah.
If you tell me a person has low serotonin, high, norepinephrine, you have no picture of that person. It doesn't seem to capture like the aliveness of the individual quite like this way of thinking does. I guess that was a bit of a tangent.
But very relevant. I think it's true. We objectify people in the DSM, and then we think that those reifications correspond to reality, or we have to make them correspond to clinical realities, when in fact, to really get a feel for a person, you have to let their story impact you, feel what it stirs up in you, hear the themes, the music behind just the notes.
Yeah. But with all that said, I guess going back to we were talking about paranoia.
Yeah.
Or paranoid, I guess how should I even refer to it? Paranoid personality style would be the...
Yeah.
Okay. So for paranoid personality style, shame and fear play a big role.
Yeah.
And you mentioned a little bit about Panksepp's fear system.
Yeah.
Can you just talk a little bit about fear, shame, and how that is a part of this?
Well, since you mentioned the fear system, let me take on the DSM in one other way.
Sure.
One of the problems of what they were trying to do, namely describe symptoms by present versus absent observable phenomena. It meant that anxiety, for example, was treated as one thing. If you have sweaty palms and rapid heartbeat and you describe a feeling of apprehension, you have an anxiety disorder. It doesn't invite you to ask what kind of anxiety. And up until we started diagnosing that way, there was in the clinical literature the notion that there were several different kinds of anxiety. There was most dominantly separation anxiety was very different from annihilation anxiety. But there was also anxiety about the integrity of the body. Some people call that castration anxiety, but it could involve any body damage. Moral anxiety, when you're afraid you're going to break your moral code. Signal anxiety, when, in the past this has meant danger. So I'm keeping an eye out now. Post-traumatic anxiety. Oh my God, this is just like Vietnam or whatever. So we wanted to know the meaning of anxiety. It turns out that it's really bad to just define anxiety disorders based on externally observable stuff, because there are two different anxiety centers in the brain. One of them is Panksepp's fear system, and the other is what he calls the panic grief system, which is the attachment system. So in any young mammal, if you separate them from the parenting, usually the mother mammal, they emit a particular separation cry. The same part of their brain lights up on an fMRI as lights up in the mother animal. If you insist on keeping them separate, you see, first of all, a great deal of anxiety in the child, also in the mother, by the way. And eventually, you see this searching kind of behavior. You can see it in monkeys, you can see it in rats, you can see it in dogs, every mammal that's been studied. And then you see depression, that it finally, the animal begins to look like there's no hope. That's the attachment system. And that is mediated, among other things, by serotonin. So the SSRIs are helpful with anxiety and depression that results from separation anxiety and depression. But there's also in the brain the fear system. It's in a different part of the brain. It's not mediated by serotonin. Unfortunately, what calms it are the benzos and the downer drugs, which is why people with paranoid personality, which is dominated much more by annihilation anxiety, the fear of being destroyed, than it is by separation anxiety, the fear of being alone. If you're afraid of being destroyed, this system in the brain seems to be the legacy of our evolutionary worry about predation, that some predator is going to eat us. So that system is calmable by alcohol and the benzos and the downer drugs. And that's why I think a lot of our patients with paranoid personality styles have secondarily substance use disorders with the barbiturates and other drugs that calm that system. But so that has implications even for medicating patients, not just for psychotherapy, to try to understand the meanings of anxiety, not just the manifestations of anxiety. So, end of that sermon. But back to paranoia. Paranoia is very much about fear and also shame and humiliation. And it involves often ways of trying to manage fear by figuring out where the danger comes from and to avoid humiliation. There's usually a fair amount of shaming in the history of people with paranoid tendencies. Their strengths involve being very acutely aware of their environment, often picking up stuff before the rest of us do. There's usually a grain of truth in even crazy paranoid ideas. They often get the affect right in other people, but the meaning wrong. For example, if a paranoid patient sees me frown, they'll assume I'm angry at them. I may have just remembered that I owe my taxes and I forgot that I have to work on them tonight. But so they'll say, "You're mad at me," but they've got the affect right. They read the face right, and having a streak of paranoia is very adaptive in certain professions, and those professions attract people with some paranoid tendencies. Police work, detective work, some elements of military work where you have to worry about where the danger is coming from next. The defenses that they use are disavowal of something in the self and seeing it as coming from outside. So it's not like there's some kind of ordinary badness in me. I think that they feel too much, they've been shamed too much to own that. So instead, they feel like, it's going to come at them from outside. So persecutory paranoia is, I'm not the person who's hostile or aggressive. I'm in danger of being treated with hostility and aggression. Or erotomania, which is a paranoid disorder where you believe that some celebrity or somebody who is idealizable is really in love with you. It's a disavowal of your own need and desire and seeing it as, well, you've behaved so seductively. You wanted me to, or Jodie Foster wanted John Hinckley to try to assassinate the president, because she was really in love with him. That's a paranoid disavowal of a different set of things. Or paranoid hatred, where you hate parts of yourself. You can't acknowledge that they are parts of yourself, and you attribute them to an out-group or another person. It's black people who are shiftless and lazy. I'm never shiftless and lazy, Or it's women who are always trying to control. I have no needs to control. The out-groups are infinite, and this is a time-honored way of handling things that we don't want to see in ourselves, is to figure out who to blame. That's essentially a paranoid attitude. I like working with paranoid people in psychotherapy. They're very sensitive people. They've often suffered a great deal, but it's also delicate work because you can't say to them, "Do you think you're projecting?" You can't interpret the defenses. What the therapy has to consist of is trying to help them be more comfortable with parts of the self that they need to disown and project, rather than to just show them how they're dealing with those parts of the self. So I think with paranoid patients, I tend to be more self-disclosing because I want to model somebody who's okay with being wrong, being flawed, being needy, being angry, being tearful, and so forth. There's something very poignant about their struggle, because they tend to have both separation anxiety and annihilation anxiety. And when they are by themselves, they don't quite know who they are. They tend to have been treated, and paranoia runs in families like many things. If you've got a parent who had to disavow badness and put it in the kid, or picked one kid to be the bad kid in the family, and is always telling the kid, you're jealous, you're stupid, all the things the parent doesn't want to admit in the self, they put in the kid. The kid ends up feeling, my parent is always critical of me. I'm just bad. But I'm very important to them. If you need somebody to be a bad object, you need them a lot. So parents of paranoid people tend to discourage separation and individuation because they need the kid to be the receptacle of all the stuff they're disowning and put. If you've ever worked with parents to try to help them with their kids who have behavior problems, most parents are happy for you to suggest some way of dealing with the kid that might elicit better behavior. But a certain minority of parents will say, you don't get it, he's bad, he's it's just, he's incorrigible. And you get the sense of their investment in this kid being bad. So paranoid people have been fused with in a toxic way and not encouraged to be separate. In fact, they've often been told that the only people you can trust are your family, when in fact the family members aren't very trustable at all. So they feel scared to be alone, but they're also afraid of being destroyed. So they suffer more than many people. And of course, in psychotic versions of paranoia, they suffer terribly. One of the reasons that the neuroleptics help psychotic people is that they are huge anti-anxiety drugs. They reduce terror and sometimes allow for more clear-headedness. Anything else you want me to say about paranoia, or should we?
Yeah. Your political science background comes out in the book when you talk about how certain cultures foster certain personality styles.
Yeah.
I liked your discussion of cultures that kind of foster paranoia in general. Can you talk a little bit about that?
Well, the same dynamics in a family that would create a paranoid child, of the parents being arbitrary, unreliable, not treating you like a separate person, treating you more like an object or something. If those are operating in your culture, it creates a paranoiagenic atmosphere. Most of us can probably recall some organization we were in at one point where we felt the authorities were too distant, too arbitrary, too capricious, or had a shtick against us because, of some reason we couldn't understand. And it makes you paranoid. You begin looking for, how are they going to get me next? And Otto Kernberg wrote a rather funny article about paranoia atmospheres in psychoanalytic institutes, because when you feel like everybody's evaluating you in a small community to see whether you're good enough, and they're going to find every flaw that you have, that's a recipe for paranoia. So under those circumstances, anybody becomes paranoid. That's another objection to diagnosing people based on externally observable features. If I'm an immigrant and I'm undocumented and I'm working for a boss who tells me I get paid well below the minimum wage, and if I complain to anybody, they're going to report me to the immigration authorities, I'm going to get pretty paranoid, but it's not because I have a paranoid personality. It's because I'm in a situation where it's paranoiagenic.
I guess want to move on to the next personality stuff. So I want to talk about depressive and manic personality. Do you want to give an overview? Do you want me to ask a specific question? To me, depressive and manic from the outside obviously look like complete opposites. We talked a little bit about the kind of different sides of the same coin. Can you talk about how they're similar and what you're saying in terms of different strategies for the same problem or same dynamics?
Yeah. A mania is basically a state of denial of all the sad things that depressive people are acutely aware of. And so, yeah, they are, it's not accidental that they're absolutely opposite. That doesn't mean they're not the same phenomenon. I mean, depressive people slow down, manic people speed up. Depressive people lose interest in sexuality, manic people are hypersexual. Depressive people feel kind of cognitively slow, and manic people are like this. Depressive people have low mood, and manic people are making jokes all the time. Depressive people are, everything is an exact opposite, because mania is a state of using what Klein called the manic defense, which is, I am not feeling all those other things. So in some ways, it's a more severe version of depression, because it's depression plus denial. And to get a depressive or a manic pattern or a fluctuating pattern, whether or not it rises to the level of diagnosable bipolar illness, you tend to have had significant loss and not been helped to grieve that loss. And for reasons that are very common in childhood, you tend to believe it's somehow your fault that you are suffering. Because very young children if they're in a bad situation, will prefer to believe there's something wrong with them that they could work on, because it gives them some hope, than to believe that, unfortunately, I'm in the hands of incompetent parents, or life is dangerous right now. That's too frightening. So children prefer to believe it must be my badness. So depression is a kind of, it's sort of it's the converse of normal grief. In normal grief, you're sad because something happened to you. In depression, you think the problem's inside. In normal sadness, you have a sense that this will pass. In depression, one of the worst things about a clinical depression is it feels endless. It feels like you don't even remember why you ever felt good in the morning. You think you were stupid ever to feel that way, because just life is a drag, and then you die, and you don't. It's like a tunnel with no ending. And in normal sadness, you get waves. If you've ever had to grieve somebody who died, you can feel absolutely miserable. But then you get involved in something and you feel like normal for a while, and then something else reminds you of your loss and you crash again. It comes in waves. Depression and depressive personality is chronic. It doesn't come in waves. You don't get any relief from it. So part of the job of a therapist is to identify what have been the losses and the things that require real mourning, and turn depression into normal grief. I had a rough childhood. I have more compassion for the kid I was. And so usually depressive patients are pretty good patients in psychotherapy, because they come in believing the problem is them. And they respond to, they're very reactive to separation. They tend to equate separation with rejection. They're grateful for the therapist's caring attitude. When they feel that you're listening to them, they start feeling better. There are two subtypes of depressive psychology that are probably too much to go into in an interview like that, but Sidney Blatt's work over 30 years established that some depressive people have the internal feeling of, I'm bad, I'm evil, and others have the internal feeling of help, I'm empty, I'm alone, I'm hungry, life has no meaning. And those two groups respond to somewhat different therapeutic styles. In the more empty, hungry group, they respond very well just to a relationship in which the other person is interested in them. In the more self-hating versions of depressive personality, the therapist has to eventually find a way to really call their attention to how their go-to automatic self-talk is, this happened to me because I'm bad. And you often have to help them see that they're attacking themselves by attacking the self-attacking part of them. So what's so terrible about that? You can't be, if you're too supportive with the self-hating kind of depressive person, they tend to get more depressed because they think you're a very nice person, but you don't get how bad I really am. So all of your good intentions at cognitive reframing to try to show them that they're really not such a bad person can paradoxically support their sense that, yeah, nobody's going to ever understand me. So it's better with that kind of depressive person to say, so what makes you so terrible? Because that has an edge to it. They can take that in because they feel like they deserve a little bit of, provocation, but you're really attacking the self-attacking part of them. I once had one of my patients told me he loved this interpretation. I said to him, I'm not disputing that you're an asshole. I'm just disputing that you're more magnificently an asshole than any of the rest of us wretched people walking the earth. And that brightened him right up. Whereas if I had tried to tell him he was not an asshole, he wouldn't have had anything to do with that. Mm-hmm. And he told me later, I love that asshole interpretation. So, there are nuances within these subgroups, but depressive and manic defenses against depression, generally you find unmourned losses in people's history, and not just unmourned losses, but losses that were handled with some explanation to the self that involves either badness or inadequacy of the self. And what you see in mania are defenses against that. I have no inadequacies. I'm on top of the world. I can make this work. I don't need anybody.
Yeah, so I think you're referring to, in terms of the two distinctions, it's the analytic versus introjective. Can you talk a little bit about the parenting that results in depression? I know you mentioned unmourned losses. What sort of other things do you see in the childhoods of depression?
Well, all of the personality types probably result to a certain degree from temperamental pre-existing categories in the child. All babies have differences in how sociable they are, how easy they are to calm, how sensitive they are. There are all kinds of ways we've discovered that temperament is an important part of personality. So it's usually about the fit between the kid and the parent. People who tend to get into the depressive personality category tend to be sensitive kids who are highly related. And if you have a parent who is critical, non-responsive, absent, not able to meet the needs of the kid for relatedness, then you can get into trouble. But I'm not sure I could exactly describe a general pattern with depressive people, because it's often more a response to serial losses. And parents sometimes don't even know that they're losses. Like a lot of people from wealthy families end up kind of depressed in a vague way they don't understand. And you look at their histories and they were turned over to a succession of nannies, and the parents didn't realize that every time they took the nanny away from the kid was feeling like a terrible loss of their primary object. So some people with ostensibly very nice circumstances and well-meaning parents suffer from depression. Other kids will get bad depression because they're misunderstood, they're traumatized, they're criticized.
When I was prepping for this, I wrote the world's worst joke, I think, for this. Why are depressive people night owls?
I'll bite. Why are depressive people night owls?
Because they're not morning people.
Very good. Terrible pun. But...
Sorry about that. I had to...
It's a good mnemonic.
Okay. Is there anything else we want to talk about with?
No, I don't think so. I mean, there's so many nuances to all these things. I get lost in the weeds. And if you think, like you just did, bringing up analytic and introjective, if you think I'm forgetting something that I've already written about that it's important for me to say, just prompt me.
And yeah, so I'll do that, and I'll also throw at the end of every video, because I think at the end of every chapter you have like recommended further reading.
Yeah.
So yeah, I'll link to all the other further reading so that it'll be an introduction for people that they can go search out and find more if they're interested.
Okay.
How much should we keep going?
Yep.
Okay. Let's move to. So the reason you had some videos online of narcissistic, where you discuss narcissistic, schizoid, and psychopathic. So I'm going to leave them to the end because if we miss those,
okay,
people can seek those out already. I want to talk a little bit about hysterical and histrionic personality. Do you want to just give it a go, or do you want me to ask specific questions?
I'll jump in.
Let's go.
This is a personality style with which I identify. I think it's my dominant personality type as a person. I would like to believe I'm in the healthy end of the dimension of hysterical personality, but people with the issues that define this kind of personality tend to be very sensitive people who somehow make a story about their life that involves that the other sex, and they think in terms of binaries, even though contemporary young people are deconstructing those binaries right and left. Very young children think about them, and people with hysterical personality think in terms of binaries. If you have an other sex parent who seems to be the powerful parent, and the same-sex parent seems weak for whatever reason, it's a problem for your identity. How do you grow up to feel like a strong version of who you are if your image of that is the weak person and the other one is the powerful person? So my father was a very good father, but a little frightening because he would have rages now and then. And my mother died when I was young, so I had the idea that women are weak and men are strong. And I also grew up in a culture, as did every woman back in the 1950s, where the voice of authority was always male and where sexism was rampant and nobody gave it a second thought. So I developed the sense that men are the powerful gender, women are the weak gender. How do you get more power? Well, you use the power you have, which might be your attractiveness, your sexuality, your capacity to be useful to men, and you both idealize them and hate them. I would like to believe I've worked through a lot of this over time, but I'm speaking somewhat from the inside when I talk about this kind of personality. And I'm doing it deliberately, you asked about that earlier, because so much of the writing about hysterical personality has been done from the outside, often by men writing about hysterical women. You do see hysteria in some men. I've had patients who were brought up in a matriarchal situation, where the only people around them were mother and aunt and grandma, and they felt that women had all the power, men didn't have any, and they do the same thing that women with this psychology have. It looks a little different. When and this is something nice I'll say about the DSM. When DSM-4 came out, Alan Francis was touring the country to give lectures about the difference between DSM-3 and DSM-4. And when he got to the personality disorder section, he taught the differences by showing film clips. And he showed a film clip of, I think it was A Streetcar Named Desire, where Marlon Brando and Vivian Leigh are in this interaction where they're flirting and they're obviously in a power struggle. And she's being the Southern Belle. I think she has a slip on, if I remember it correctly, and she's batting her eyes at him. And Brando's in a T-shirt, and he's got cigarettes rolled up here. He's opening a bottle of beer. It has this big phallic explosion of beer. And so Alan Francis shows this scene, and he said, so what's the diagnosis? And we said hysterical or histrionic, which, I wish we hadn't substituted that word because it used to be the word for the more extreme version of hysterical. And he said, which one? And he pointed out that the Marlon Brando character was doing exactly the same thing the Vivian Leigh character was. He was hyping up the stereotypical aspects of his gender in the service of power over somebody of the other gender that he felt too. And I have worked with a few men over the course of time that had these dynamics, but they're more common in women because women are more likely to live in circumstances where they get the message that men have the power and women don't. And this can create conflicts around sexuality. How do I open myself up to this person who might misuse me? Down toward the borderline and psychotic end of the spectrum, you find sexual abuse in the histories of people who have hysterical dynamics. That's a particularly destructive criminal way of dominance. It's when an older male relative molests a little girl. I didn't have anything near that. In fact, I think my boundaries were very respected growing up. Nevertheless, I can identify with the feeling that it's a little dangerous to be in this world run by the other. And you can take several different ways of dealing with that. One way is to be very seductive. Another way is to have a certain kind of competitive quality that you try not to make too obvious. Another could be avoidance. In some Middle Eastern cultures, there's a lot of hysteria. And in Freud's time, there was a lot of hysteria. And it's an interesting group because it was what Freud started with. He was trying to understand people with fairly severe hysterical disorders. And his original theory was that they'd been sexually molested. And later on, he decided that couldn't be true of everybody. And that was probably a mistake because I think his first theory was righter than his second theory, which was that there were these universal fantasies that went on. But hysteria is a kind of overstimulation. Often when sexuality feels threatening, other people's sexuality can feel threatening. Often people with hysterical psychology, their boundaries have been invaded. When I taught in Iran a few years ago, people told me, all you have to know to help people in Iran is hysteria, meaning that it, like the culture that Freud was working in, was a culture in which women were expected to be modest, not to trouble men with their sexuality, to cover themselves, not to be ambitious, not to want an education. All these things were true of post-Victorian Austria. You're supposed to be modest, you're supposed to be helpful, you're not supposed to be too ambitious, and so forth. And hysteria at that time took a very inhibited version, the fainting type of somatizing versions of hysteria. In our contemporary society, we tend to see much more the flip side of that, the enacting sexuality. It's still not fully integrated with real intimacy, but the kind of provocation, exhibitionism, Barbie kind of. If you saw the movie Barbie, there's a lot of hysteria in that. One feature of hysteria that people often don't understand is that people with hysterical psychologies seem to exaggerate, and they seem to act out stuff. They don't feel authentic. In fact, Philip Bromberg once memorably said that a hysteric is someone pretending to be who he really is. Meaning, I think what the dynamic is, if you have a hysterical psychology, you're afraid of being dominated, being put down, being patronized So one defense against that is to sort of say what you have to say, but in a kind of slightly self-mocking or false way. So a person with a hysterical psychology, if I'm your patient and I have a hysterical psychology, I might say to you, I was so angry. And you're sitting there feeling like, oh, God, do you have to put on a show every time? I don't even believe you're angry. This is phony. What you find out when the person eventually gets safe in therapy is that they were angry, but they were anxious about being seen as angry. So they were kind of telling you they were angry, but making fun of themselves at the same time. So, if you weren't going to take them too seriously, they had control of the ways in which you weren't taking them too seriously. Because over the course of time in therapy, the same person will get to the point where she can say, I was really angry. And it won't be false anymore. But that often is a problem for people. If you're the other gender, or if you're the love object gender of a hysterical person, and there are gay versions of this as well that are too complicated for me to get into, and I don't think I know enough about them to mouth off about them, but you're often in the role of the patient being seductive with you, or the patient feeling false to you. And what's mostly helpful to people like that is for the therapist to be very respectful, patient, not interpret at the person, because that just makes them feel dominated again, or impinged on, or penetrated, but to set an atmosphere where they can find their voice and they can feel a kind of empowerment as who they are. That was something that changed in my own psychoanalysis, that I used to have dreams after I'd been particularly effective in something that I was a boy. It was the boy in me achieving that. And by the end, I stopped having those dreams because I'd somehow integrated that I could be a reasonably powerful person as a female. It wasn't as if power was male and impotence was female. So I have a feel for this group, but I also know that, especially at the borderline and psychotic end of the spectrum, they're really difficult. They create so many problems that you often can't get into the dynamics because there's too much drama going on in their lives. Zetzel's work that I cited earlier starts off with the old nursery rhyme, when she was good, she was very, very good, and when she was bad, she was horrid. Meaning at the psychotic end of the spectrum, they're creating so much drama all the time you can't get near psychotherapy. You do damage control all the time.
You brought up a lot of things that I want to talk about. One thing you mentioned is that you have an inside view of this personality, and I think you mentioned you have depressive as well.
Yeah.
And this, I'm probably not going to put this in, but also how accurately you describe schizoid. It almost just feels like your understanding of schizoid is like a love letter to schizoid, because you mentioned that you tend to, your husbands have that dynamic. And you mentioned you were going to write a paper about that particular dynamic.
Yeah, I don't think I ever did.
Oh, okay.
About the combination of the hysterical woman and the schizoid man.
Yeah, and how it's a nice
it's a
match.
pretty common combination.
Yeah.
Yeah. Well, yeah. I am very attracted to schizoid people because they have integrity. There's a certain way in which hysterical people are vulnerable to trying to be whoever you want them to be because they are worried about your power. And schizoid people are worried about something completely different. They're worried about impingement and overstimulation from the outside, and they like being alone and standing alone. And so to a hysterical person, the schizoid person's capacity to be clear about their values, their beliefs, where they differ from other people, their personal quirkiness, not caring whether they're acceptable to other people, all of that's very attractive. Mm-hmm. And they're similarly sensitive people. They just took a different route with it. Mm-hmm. But these two types, and the schizoid person, I've seen the genders in the other combination, but I've more often seen a hysterical woman and a schizoid man. But on the schizoid man's part of it, they admire the woman's comfort with other people, her social facility, adeptness. her caregiving. But the two of them, when they get together, they have to work hard not to drive each other crazy, because when she's upset, she moves toward him, and when he's upset, he moves away. And you get these pursuer-distancer dynamics in the dyad. But if you really appreciate that difference, he can learn to come toward her if she's upset, and she can learn to give him space if he's upset. And it's a pretty nice combination. I speak from experience of a good marriage of almost 40 years with my first husband, and now almost 10 years with my second. So.
So I'm going to bounce back to you were talking about the therapist's reaction to hysterical, and I realized, can you talk a little bit about the two types of countertransference that you wrote about in the book? Not in general, the concordant and complementary. Yeah.
That comes from the work of Heinrich Rocker, originally a South American analyst. In Freud's day, the general attitude toward the therapist's transference to the patient, the therapist's emotional activation by the patient, was, if you are feeling anything other than a benign physicianly attitude toward the patient, there's something you should work on in your analysis. And sometimes that's true, but I think Freud must have been very well defended to feel like he was always in this benign physicianly attitude toward his patients, because most of us find that when we sit with another person, we're always activated in our emotional system. We feel things toward them. Some patients we feel very strongly. Sometimes it's positive, like, oh, I want to rescue and reparent and, hold this child to my breast and take her home. And sometimes it's very negative, like, oh my God, if this lady says one more bitchy thing, I'm going to die in here. But Rocker pointed out that that's not a result of being insufficiently analyzed ourselves when we're having that reaction. A big way that patients communicate with us is to let us know through, he didn't say this, we know this now, right brain to right brain communication, how they feel or how other people felt toward them when they were growing up or even ongoingly. So it became, as a result of the gradual normalization and depathologization of the fact that we all have these emotional reactions to patient, to think about our countertransference as data. Why am I finding myself bored? This patient should be interesting. Is the patient maybe putting me in a trance? Because they describe trauma and dissociation. I think I'm getting a little dissociation here and thinking of it as boredom. But, in other words, instead of just getting self-critical, oh my God, I'm not paying proper attention, I am insufficiently analyzed, or else I would be right with this patient, you think, wait, my interest has lapsed. What's going on here? Or I'm finding myself irritated with this person. Is this how the person feels all the time? That's a concordant countertransference, where the patient is evoking in you what the patient typically feels. Or am I feeling what other people felt toward the patient? When I sit here finding myself critical, where I'm in a profession where I believe that being non-critical and accepting is important, somehow am I being like the patient's critical mother? So very often you don't even have the story of why you're feeling a particular way, but if you can note it and then explore what it might mean, like you can say to a person, I just noticed my mind was starting to get distracted. Have you had any problems keeping your own thoughts in a straight line? Or do you find yourself distracted or dissociated or like losing touch with your thoughts at any time? Because that's not typical for me, and I just wondered, am I picking up something that you struggle with? Yeah. Or sometimes you can kind of use your countertransference more directly. If your patient is conscious only of sadness and you find yourself angry about somebody that's hurt them, you can say, I get that you're very sad. Is there any anger there? I'm feeling a certain kind of anger about what happened to you. It's interesting that you're not. I think I'm carrying it for you. I mean, there are many ways of working with countertransference, but it's useful to figure out which kind it is. Patients tend to communicate, the control mastery theory people say that they test us. And this is their orientation to therapy is based on empirical analysis of actual therapies, that patients test us to see if we can give them a different experience than what they are expecting. And they test us in two ways. One is, are you, like the people who screwed me up, going to treat me the same way I was treated? That's what they call a transference test. Are you, like my mother, going to criticize me? Or are you, like my father, going to abandon me, or whatever? The other kind of test, and those tests are where you find yourself often feeling what a parent felt toward the child. The other kind of test is what they call passive into active transformation. They treat you the way they were treated, and then they watch you to see whether you have a way of reacting to that is different from the only ways they had at hand when they were a kid. So sometimes patients will mistreat you pretty badly, and they'll need to know that you can set boundaries, for example, and treat your time respectfully, or they may tell you a litany of all the things you're doing wrong, and you find yourself thinking, this is exactly what happened to them when they were a kid, and their parents just constantly carped at them. And then you try to use your own experience as a way not only to find empathy with them, but to figure out how to put that into words so they can kind of see what's going on, see the pattern, and maybe work out a different way of reacting.
All right, should we move on to the next one where we ready to keep going?
Yep.
Fantastic. When you're talking about that, it reminded me, I kind of have, in your book, you mentioned that like people on the borderline level of organization, it's, just my luck. I got a therapist just like my parent.
Yeah.
I like that, and I joked at that with my girlfriend in terms of like, I had the worst luck. Dr. Moses, I'm going to edit his name out, treats me just like my dad. Okay, so now, do we want to move, is there any more to say about hysterical, histrionic?
Probably there's a lot, but that's enough.
Of course, but there's nothing that you have burning.
Yeah, I'm probably forgetting something important, but...
Okay, should we move to obsessive compulsive?
Yeah.
All right.
I've talked a little bit about this already, illustratively, but basically this is a psychology about trying to be in control, and one gets the sense that some kids have a temperament where they like to be very well organized, but it also will contribute to your being very into issues of control and orderliness and so forth. If you have a very controlling parent, or if they prematurely try to control you. Freud got all excited about the correlation between early prematurely...
Hello. Hi. You want to get in front of the camera?
No. And I haven't been waiting out there for the very moment that you finished. I was curious to set up, because I'm supposed to do some interview too.
Oh, my setup's a little janky. That's a seasonal affective disorder light.
Okay, that works.
So I can save some money on getting another one.
No, boys the spirits.
Yeah.
Okay.
Anyway, we were talking about your work a little bit.
Don't.
Because Greg was saying he's a doctor and he's gotten no training at all in working with...
The thought of therapy
Psychotic
with
patients.
schizophrenia is a
course.
foreign concept.
Of course. And once the idea of cleanliness in the operating room was a foreign
Yeah, it's
concept.
just...
Yeah, and frontal lobotomies.
Yeah, we're all the rage.
Yeah, exactly. They were the rage. That's right. No, it's a very important public health issue. So anyway, carry on. I'm going to go for a long bike ride.
Okay.
So, and,
Maybe next time we'll have you on the couch. Okay.
Back to obsessive compulsive people. These are people that you can, if you have Freud was very excited by the fact that very often people who got very obsessive compulsive had been toilet trained too early or unempathically. And he liked to think of it as a fixation at what would be the normal phase of interest in getting control over toileting. And I don't think he was entirely wrong about that, but I think it's more important the parents who are going to be controlling when the kid is 2, 2.5, 3, or pushing them toward toilet training too soon is the same kind of parent that's going to be putting them on a schedule to eat when they're babies and is going to have all these rules about how to behave when they're older. So it's more the issue of controlling parent than anal fixation, really. But it is kind of interesting that the issues that obsessive compulsive people get worried about have to do with cleanliness and timeliness and cooperation versus rebellion, all of which are issues if you're unempathically toilet trained. But it involves any kind of dyadic effort to control the child. So very often you find that people who are obsessive compulsive had very demanding, controlling parents. Sometimes you find the exact opposite. They were brought up in chaos, and so they had to get more demanding of themselves just to make their life comprehensible because there wasn't any control in the situation. So again, you see this odd thing of the domination of something or the total absence of something makes it the theme that organizes a person. They're especially interested in the control of sadness and anger. I mean, obsessive compulsive people can be angry, but only if they feel it's realistic and justified to be angry. So they can be very angry if somebody is unfair. But it's very hard for them to find normal anger of the sort of, I'm just pissed off because I didn't get what I wanted. That feels too infantile to them. And they often are very defended against the more needy, distressing feelings. Like they have this idea that crying is losing control somehow, as opposed to just expressing an affect. A lot of things are framed in their mind as control, discontrol. And they may apply this wish to control to almost all the affects, so that Wilhelm Reich called them living machines. They're trying to be like Mr. Spock of the original Star Trek. Like, I am only intellect, I am not emotion. And so their relationships suffer because they don't have the range of pleasure that comes when you're not affectively stultified. In psychotherapy, they need a therapist who can help them become more comfortable with their emotional life and really question the fact that feeling things is tantamount to loss of control. They tend to have very high moral standards, sometimes too high for their own good. Like there's an obsessive-compulsive version of perfectionism there. I'm supposed to be morally perfect, and they can't allow themselves any slack, any normal human foibles. Perfectionism differs across the personality types as to what it means. For example, in more hysterical people, it often has to do with I want to be the perfect good girl so nobody gets mad at me. Okay. In narcissistic people, it often is I have to look perfect. If I look perfect, then I don't feel shame. So in the hysterical person, it's a defense against fear, and the obsessive compulsive person, it's a defense against the feeling of badness, and in the more narcissistic person, perfectionism would be a defense against shame. So obsessive compulsive people, you want to help them loosen up. Sometimes group therapy helps them to do that. Sometimes humor helps them loosen up. Usually therapy takes a while with them.
I asked a similar question, and I liked your answer with regards to psychotic level organization compared to schizophrenia. For here, how do you conceptualize OCD proper, like the word, DSM, OCD, and obsessive compulsive personality?
Well, you can have an obsessive compulsive personality and not have any obsessions or compulsions. Also, you can have a more obsessive personality without compulsivity, like people who organize their self-esteem through thinking, like philosophers. That would, almost by definition, being a philosopher is thinking about things all the time. And you can be a compulsive person, again, without compulsions, meaning you value doing and you want to be a very good craftsman, for example. You might not think a lot, but you want to get your carpentry perfect, because it gives you great pleasure to do that. Your self-esteem is organized around that. Those are healthy versions of obsessional and compulsive. Obsession just has to do with thoughts, and compulsion has to do with acts. And if they're not intrusive, like in OCD, they're just personality tendencies to think, or to organize yourself around thinking, or to organize yourself around acting, or both of them. So with OCD, at least at the neurotic level, it's crazy. You've got a problem here. You've got this ritual. You've got this compulsion. You can't stop thinking about certain things. When you drive, you're always thinking you hit somebody. At the borderline and psychotic levels, you have all those rituals and compulsions, but they tend to be egocentric. In other words, they tend to you tend to think of them as natural, and you don't know any other way to be. At the psychotic level, you feel like if you're not doing them, you're in terrible, terrible danger. Realistically terrible danger, not just like you feel like you're in terrible danger. So the term as used for the personality is, like a lot of personality things, we got the term because we were looking at these dynamics in certain kinds of symptom formation, but what we realized that the same dynamics can pervade personality without necessarily creating symptomatic problems.
Any other comments or things that we can talk about with obsessive and compulsive?
I think that's pretty good there.
I think so too. All right. How are we doing?
I'm beginning to flag.
Yeah. Can I ask one more question?
Yes.
Okay. And I was going to ask this for the hysterical, and then I forgot to. Can you simplify the Oedipal complex?
Oh, no.
No? Okay.
So much for that question. Well, I'm not sure I can simplify it, but I can say that something happens around the age of 3 to 6 where kids are, for the first time, able to see that two other people might have a relationship with each other that's not about them. Up till age 3, they're pretty egocentric, It's like, this is about me or it's about you. But they begin to expand around the age of 3 or 4, where they get interested in people's relationships with other people. Now, Freud got kind of excited by that, by the child's fantasies about what the father and the mother were doing. And it is true that many kids, especially in this kind of culture, which has a nuclear family and makes a fishbowl out of the 3 parties, the 2 parents and the child in most setups, that we create a kind of intensity around that. And sometimes when my own young relatives talk, I feel like they've been reading Freud. I remember a conversation between my two daughters and my niece when my niece was just turning 3, and my older daughter was, I think, 10, and my younger daughter was 7. And the 4 of us are having dinner together, and my niece announces, "When I grow up, I'm going to marry my daddy." Okay. And my younger daughter says, "Oh, I know just what you mean, Emily. When I was your age, I wanted to marry my daddy too." And Emily kind of hears the implicit no in that comment. And she says, "But I'm going to marry my daddy." And my younger daughter, who is an empath, says to her, "I'm sorry to tell you this, Emily, but you're not allowed to marry your daddy. There's a law against that. You can't marry anybody in your own family." And Emily thinks about that in a moment and says, "My mommy and my daddy are married to each other, and they're in the same family." And Helen then at this point throws her hands up and turns to her older sister. And her older sister says, "Mom, remember when I was Emily's age and I used to tell you when I grow up I'm going to marry Daddy?" I said, "Yeah, I remember that." She said, "Well, and you used to say, 'I'm sorry, Susan, you can't do that because I'm already married to him.'" And I said, "Yeah, I remember saying that too." She said, "And I used to say, 'That's okay, you'll be dead.'"
Is the whole family reading Freud?
Exactly. I mean, I thought I should have tape recorded this. Nobody's going to believe this. But I guarantee it happened pretty much like that. So you hear that, of course, children are, when they start getting interested in how people relate to each other as grown-ups, they want to run off with the people that they know and that they love. And it bothers them that these people are taken. Okay? But more important than that, they have reached a developmental level of being able to see that there's something between these two that's not about them. So it's a triumph over the egocentrism of the younger years. And most people who have been interested in stage theories of development, like Peter Fonagy, for example, he got much more, Freud was interested in the sexual fantasies that went with that, but Fonagy was very interested in the fact that the kid is beginning to learn to mentalize. In other words, to see other people as subjects, not just objects, and to get interested in what's in their minds. What is it like to be married to Daddy? Or how does Daddy feel about Mommy? Or how does one mother feel about the other mother if you've got gay parents, for example? It doesn't have to be a heterosexual dyad, although Freud assumed the normality of that. You see these dynamics even in single-parent families because the kids will realize that their parent has relationships with other people. And so you see the same transition to the capacity to imagine other people's minds. And that's the importance of that phase, because some people don't fully master that phase. And there are many people out there who treat others as objects, who can't really imagine others as subjects, who project instead of empathizing, And a lot of our patients have trouble imagining, for example, that we might wish the best for them. In certain states of mind, they are convinced we're exactly like a pathogenic parent. And that's a failure of mentalization. So when the old analysts talked about pre-Oedipal versus Oedipal patients, they meant that the patients they were calling pre-Oedipal were people who were still stuck on the question of who am I and how am I going to use you to get what I need. And the people who'd gotten to the Oedipal level had internalized some capacity to see others as subjects and to see that they would have an internal conflict that, like the child in the traditional Oedipal situation feels like, I want to kill off one parent so I can have the other one, but I love that parent. So you get the capacity eventually for normal ambivalence and feeling two ways about something. You know, my daughter, who said I'd be dead, obviously loves me too, and that went without saying. But if you don't get to the Oedipal phase, you tend to feel only one side of that kind of thing at a time, which can create a lot of trouble for you.
Wonderful answer. As with most things, when I read things, it's like, that makes no sense. And then when you say it, it's like, obviously, of course. Really appreciate it. Oh, one last comment. Just looking through your resume, I saw the 3 blonde chicks.
Yeah, that ended with COVID.
What was that?
Oh, that was a singing group, a semi-professional girl group that in my spare time, I have sometimes done some cabaret singing. And the 3 of us used to perform periodically in small venues.
That's awesome. What kind of things would you sing?
Blues, some of the easier to harmonize soft-ish rock songs, some folk songs, stuff that was melodic and interesting to try to sing in 3 parts.
Awesome.
Yeah.
I do I'll usually put a cover song at the beginning for like the intro. I tend to pick songs that are like angry and oppositional.
Uh-huh.
Do you have any recommendations or songs that come to mind to put at the beginning of one of the videos?
Well, my daughter, the empath, is a professional singer, and she is a melodic punk rocker.
Punk is exactly what I'm going for.
She's in a group called One Fall that recently won the Boston Rock and Roll Rumble. And you might take a look at their EP and see if there's a song that
Fantastic.
suits.
I'll definitely take a look.
It's One Fall, like one autumn.
Mm-hmm. And can we link to their Spotify on the
Sure.
on the video? Wonderful.
Sure.
All right. Let me wrap up. Any other comments or things that we should?
No, thank you for, you've obviously studied my stuff in a way that